And thank you so much for taking time out of your day, because I appreciate pressures are particularly significant at the moment. So it's great of you to join us over this lunchtime to share with us the webinar that we've got in store for you today. So my name's Kate Taylor and I work as a clinical safety specialist, and I'm a senior nurse currently supporting this key piece of work within the digital nursing programme as part of the national CNIO team. So it gives me great pleasure to be chairing the session today. Now, before we get into the session, I do have just some housekeeping arrangements that I need to run through just to make you all aware of how the session is going to run, how you can ask questions and some of the technical support. So bear with me, I have a crib sheet just in case I forget to tell you anything. So as you join the session today, you'll notice that your camera and your microphone have been automatically disabled. And that's normal in a webinar, I'm told, so please don't think that there's been a malfunction there. We are recording today's session, and that's really so that we can host it on our website for anyone who's been unable to join today. So if you have a problem or you're uncomfortable with the session being recorded, there is the option to drop out now and watch it back at a later point in time. But as I say, your cameras are off, so I'm sure that everyone will be comfortable with that. We've got the opportunity throughout the session today for you to pose questions to the panel, and you'll notice in the top bar of your meetings chat that there is a Q&A section there. The chat function has been disabled, so if you do have questions as we go through the webinar this afternoon, we would encourage that you pop those into the Q&A. These questions will be moderated, and if there's a question in the chat box that you think, oh, I wish I'd asked that, or it's of particular interest to you, if you like it, that will help us to pull out some really common themes, and we will make sure that those questions are articulated across to the speakers today. In the event that we don't get to your question, we will post up later onto the website those questions and answers, which I'm sure our speakers will help us to come to pull together after today's session. We'll also make sure that all of the materials from today's session and the recordings will also be uploaded onto the website, and any links to references or resources will be there. So there'll be lots of supporting information after the event today. And please do, if you have any problems throughout the session or you're sort of experiencing any technical issues, if you pop it in the Q&A, one of our moderating team will be able to pick that up for you. So I think that's probably all on the housekeeping front. I'll just maybe, Ellie, if you could just pop me to the next slide. Fabulous, thank you. So what's today's session all about? Well, as we know, the What Good Looks Like framework for nurses was launched in March of last year. Some of you may have been at Rewire at the conference in March. I can't quite believe it was a year ago. So some of you may have been there at the launch. And that's really where we sort of started the idea of the framework for digital transformation for nurses. And what the principle of this guidance allows us to do is undertake a self-assessment against that framework, really allowing us to address and understand what does exemplar look like, what does good look like, and how can we achieve that. It enables us to develop that action plan. So in order to support organisations and individuals to embed the framework, we've developed this series of masterclasses. There are 7 in the series, each one following each of the success measures of the framework. And today is obviously the second of those. Some of you may have joined the first masterclass, which was held back on the 10th of January. And in that, we heard from colleagues across the region and across secondary care about well-led, about leadership, and how that collaborative approach between the chief nurse and the chief nursing officer was really crucial to embedding that part of the framework. If you haven't had the opportunity, if you were unable to attend, or you haven't had the opportunity to watch the recording, I would encourage you to do so. It was really inspiring, and it certainly gave me some food for thought. So please do look on the website and watch that back if you haven't had the opportunity to do so. So what's today's session about? Today's session is on looking at the success measure SMART Foundations, and this is really about how do we ensure that we have the right foundations for digitally enabled nursing care. And I think there's probably no better time to reflect on than the past couple of years. Through the pandemic, we've really accelerated our response to digitally enabled care, and we did that at quite considerable pace. So today's session hopefully will give us that opportunity to pause for thought, to reflect on some of that digital transformation change, and help us to understand some of the science behind that. And some of the behaviours, of course, that helped us to make that change in a positive way, but perhaps there were some behaviours that hindered that change. So we've got a real treat in store for you today. We have a unique opportunity with our behavioural science team here at NHS England. They're going to share with us some of the behavioural science. I've had privy of the slides and I can tell you it looks a great lineup this afternoon, and I'm hopeful that you'll take away some really practical tips and tools that you can take back to your organisation and your area of influence. So enough from me. I'm going to hand over now to our colleagues Dan Berry and Terry McElvaney, and they're going to take us through a short webinar looking at behavioural science with the aspiration that we will achieve SMART Foundations. And don't forget, if you've got any questions, if you pop them in the Q&A section, we'll get to those throughout the session. Over to you, Dan.
Yep, thanks, Kate. Hi, everyone. So I'm Dan. I work in the Behavioural Science Unit in NHS England with Terry. So I'm going to kick off this session and then hand over to Terry, and then I'll wrap up at the end. So you're going to hear a bit of both of us. Let me just, I'm just going to share my screen just to switch. While I'm doing that, I'll just recap the broader agenda for the next hour-ish is I'm going to do a bit of an intro to, cut through some of this jargon of what behavioural science is and why it's relevant to people in jobs like ours, because this jargon might be new to some of you, and we don't want the jargon to get in the way of being able to apply this in the real world. So there's a bit of an intro. Then we get into the good bit, which is led by Terry, which is when we're gonna give you essentially a toolkit of how you can go about applying these approaches from behavioural science into, all of the priorities that we have. So it's the practical bit, and that's full of examples. So really, what we want to do is to, excuse me, I've skipped ahead a slide. Really, what we want to do is to give you practical stuff that you can take away. And then I'll just round off at the end with a bit of more of the process, how you might go about, the nuts and bolts of doing this in your team or in your organisation. So that's the less interesting bit, if I'm honest. So we're going to dwell on the fun bit. And there's a couple of opportunities for questions. As Kate said, all of these materials will be available after. So don't worry about if we're sharing quite a lot and you're eating your sandwiches and there's a lot to take in. You can have the slides and the recording, of course. And the key bit, the toolkit, that's freely available to download, so don't worry if you can't recall everything we show you. I'm going to get going, in fact, with a game. So I thought you might be eating your sandwiches, so if you want to play along with the game, I've called it an experiment actually. All you need to do is get something to write on. So you might have a pen and paper, or being digital types like us, maybe open a window on your laptop. You don't need to show anyone what you're writing, but you just need something to write on. So I'll just give you a few seconds to get that. So what the game is, in the next few seconds, I'm going to read out a list of words. And then when I've stopped reading out those words, I want you to write down as many as you can remember. That's the game. And then I'm going to ask you some questions and we can all take part in, there's a poll function that will appear when we get to that bit. So don't cheat and write down the words while I'm reading them out. I can't see you, so I'll have to trust everyone, to be honest. There's no prize anyway, so there's no benefit of cheating. But so here are the words, and then when I've finished, write down as many as you call. So here we go. Dream, bed, night, mattress, snooze, sheet, nod, tired, night, artichoke, insomnia, doze, blanket, night, alarm, nap, snore, pillow. Okay, I'll give you 30 seconds or so to write down as many as you can remember. I'll give you a 5-second warning. Okay, about another 5 seconds. Okay, everyone stop writing. Anyone joining late, you'll be thinking, what on earth is going on, as we, ask things that you think, what's this got to do with jobs, but all will be explained. Okay, so if you stop writing, and now I'm going to ask you, I think I've got 5 questions to ask you about those words. And the first question, hopefully this should appear in a poll, is how many of those words, have a look through your list, how many words did you write down? And there's a few options to pick from. So if you want to play along, just click, have a look through how many words did you write down? Let's see what's the results. Okay, these are appearing. So most people got, well, it's a bit of a variety. Most people got between 7 and 9. Few very, people with strong memories got lots of the words. Some people got 16. Wow. So basically the first lesson here, and this is where I'm going to start bringing this back to what on earth has this got to do with smart foundations for our job and behavioural science, is it's about memory and recall. So it's quite hard to remember a list of words, but there is a lesson here that even when we actively concentrate on information, our brains can't retain that information as well as we might want to. So a lot of the information we immediately forget. So there's a lesson there about how we communicate the benefits of digital and tech in our jobs, that the people we're speaking to, they might just forget a lot of it straight away, because that's just the way our brains work. But the next questions relate to, it's not, so if most of you on average only remembered about 7 to 9, so only about half of the words I asked actually, because there was 18 in the list. What you remember and what you forget is not random, and that's the experiment. So here's a few more questions for you. So the next question is, have a look through your list, and did you write down the words dream and pillow? Did you write down dream and pillow? And here we go, the results. Oh, that's a nice clear result, isn't it? 80% of you wrote down, oh, it's shifting a bit lower. Anyway, the majority, big majority, got the words dream and pillow. And the reason most people tend to recall the word dream and pillow while forgetting a lot of other words is because those were the first and last in the list. So in psychology, we might refer to that with fancy terms, primacy and recency. We tend to remember what comes first and what comes last. So that's an interesting point, maybe not too insightful. Another question, have a look through your list. Did you write down the word artichoke? I expect lots of people got the word artichoke. Oh yes, resounding yeses for artichoke. And I think it's obvious why, because it doesn't really fit with words, does it? They're all like dreaming and sleep and so on, and artichoke doesn't fit. So there's a knowledge we might.
Apologies, everyone. We seem to be having some technical issues.
Yeah.
Dan, you're back.
Sorry.
You.
There we go.
That's okay.
Brilliant Wi-Fi. Okay, I
You
will crack on.
Me then, Dan.
Yeah, well, me too. There we go. Digital and tech in the NHS, eh?
Back to the experiment.
Yeah, back to the experiment. Okay, so where do we get to? So the next one, so we've done artichoke. The next question is, did you write down the word night? So have a look through your list. Did you write down the word night? Oh, everyone got night. Good. So you might have spotted why that is. I actually said the word night 3 times. So there's a again, I don't think this is particularly insightful. There's a repetition effect. We recall things better if we hear them more than once. And actually, I do think that is interesting in the NHS, because we often there's a bit of change for change's sake, in my opinion, and sometimes just sticking with the tried and tested messages is actually a good way to cut through, given this problem about memory. Next question: did you write down the word sleep? Let's give everyone a second here. Most people got sleep. So we're at, well, it's about 50-50 actually. So interestingly, I didn't say the word sleep. So this is the nub of this experiment. So most of you got the word sleep, and the reason you did that was because all of the other words were about sleepy type things, weren't they? Beds and pillows and nights and dreaming and so on. And what your brain did was it filled a perfectly logical gap. Was that, well, surely the word sleep is there, even though it wasn't. And you can go back and listen to the recording, and if those of you think, oh, I'm pretty sure I heard the word sleep, I really didn't, and you can check. And that's a false memory effect, but it's one of those examples, and we're done with this experiment now. It's an example of behavioural science and how there are some systematic ways that our brains work, how we make decisions, and how that informs our behaviour, what we do, that can sometimes seem a bit strange or irrational. But we've evolved in that way for really good reasons. So if you thought the word sleep was there, that probably because in most cases it would have been in a list of words about beds and dreaming and pillow. And in that case, you filled a gap that was incorrect. But in many other cases, it could be correct. And what behavioural science is, it really hones in on these types of factors that drive our behaviour and decision making. And that experiment we'll move on from now was just about one aspect of things that drive our decision making and behaviour, just memory and attention. There's loads of other things to do with knowledge and skills and motivations and so on. And behavioural science is the science of understanding all of those things, but honing in particularly on a subset of factors that typically in the NHS maybe we don't think of enough, and there are opportunities to think of a bit more. So I often show this slightly daft picture at this stage, which I think paints, it brings to life exactly what we mean by behavioural science. So on the one hand, there are lots of things that drive our behaviour. So think about locally when you're trying to embed, digital and tech best practice in your workplace. There are some fairly obvious things that might come to mind to support that, or that might get in the way. Do people have the knowledge and skills they need? Do people have the resources they need? And it's not always easy to solve those, actually. There can be some quite significant barriers about resources, for instance, but we at least quite understand them quite well. And yet there are another whole bunch of things, and this draws us back to what Terry and I really focus on into the behavioural science team in NHS England. There are another whole range of things that are a bit harder to put our finger on. So it's not so much about not having the knowledge to do something or the ability, but things in our environment around us, or when we take cues and make associations and go with gut reactions, those sorts of things, emotions maybe, and habits. It's those sorts of things that in the NHS, I think we can often find it hard to put our finger on exactly what we mean, and therefore don't know exactly how to overcome them when there are problems, or to go with the grain of them when they're helpful. So this picture, people taking the escalator up to the gym, they know that going to the gym is a good way to be physically active, and they're able to walk up the stairs are next to the escalator, yet something about the environment has made them do a seemingly irrational thing. And that's really what we're honing in on for this session today, and the resources that we'll share with you. It's understanding these types of, in our jargon, behavioural factors that influence so much of our decision making and the actions that follow through. So if you have come across behavioural science, or sometimes it's called behavioural economics or behavioural insights, it's all the same sort of thing. Just very quickly, just to wrap up this introductory part, the scientists who work in these areas, including now 3 winners of the Nobel Prize for Economics, they tend to use this analogy that our brains work using 2 systems of thinking. It's only an analogy, but it's really handy, I think. One system of thinking is like Sherlock Holmes. We like to think we think in a reflective, controlled, effortful way, especially when it comes to decisions we make at work, important decisions about healthcare and money and resources. And this is true. This is how all of us make some of our decisions. But there's this other system of thinking, which is a lot more like Homer Simpson than Sherlock Holmes. It's about going with a gut reaction, something that's fast and effortless and feels good enough. So it's less about carefully weighing the pros and cons of something, and more with going with that automatic, effortless decision. And this is the way that all of us make many more of our decisions through the day, including in the workplace, but in all aspects of our lives. And it's not about being clever or stupid. I really want to underline this point, because if you're a fan of The Simpsons, you'll know Homer Simpson is not a clever character. It's not about clever or stupid. It's about going with a sort of fast gut reaction as opposed to carefully weighing the pros and cons. And this is what we're really honing in on. So after we take some questions about this intro bit, when you see some examples of this from Terry, keep in your mind that it's this sort of response that these examples are aimed at. It's the automatic Homer Simpson type response in people, in all of us, that we're trying to design services, design communications, design support and guidelines around. Just a tiny bit more in the intro, because it can feel a bit doom and gloom, I think, showing, if you accept this premise that all of us are a bit Homer Simpson and a bit less Sherlock Holmes, it can feel like bad news, like it's a problem to fix. And sometimes it is a bit of that. But actually, going back to the game we played at the beginning, just to say our humans have evolved in this way for really good reasons. It means we can do remarkable things like reading the text on this slide where pretty much every word is spelt incorrectly. We can read it pretty well. And it's because those fast, effortless reactions can be really helpful, but sometimes they're not. So sometimes they're helpful and we should go with the grain of them. Other times they can get in the way a bit, in which case we might need to do things that are sometimes slightly different to overcome those barriers. And that's it. I've just got one more example before we take some questions, but essentially the premise of this whole session today is that in our doing the jobs that we're all doing, we have a Sherlock Holmes bias. We tend to think that the people we're engaging with to, make those digital and technological changes we want are like Sherlock Holmes, when actually they're a bit more Homer Simpson. So that's basically the premise. If you keep that in the back of your head, how can we get to that Homer Simpson type response in our colleagues and the other people that we engage with? Finally, from me, and I will pause for questions, is what you might have accepted at this point in the presentation, especially if you're new to behavioural science, behavioural insights, is, well, yeah, I understand this might be how consumers in a shop, if I'm in a supermarket, I can appreciate how marketing tricks might get to me in this way, but surely not us, professionals in the workplace, highly educated, trained, conscientious clinicians and managers. Surely we're not susceptible to these weird ways of behaviour. And I found a great example. It was published in a journal a couple of years ago. That I think really paints the picture that essentially we're all humans and we all respond in these ways. And the basic insight is about how prices are set out. Pretty much every shop in the world sets out a price as £4.99 rather than £5. And the reason that's done is because what your brain does is you look at the 4 and you make that quick Homer Simpson type assumption that, that it cost about £4, when of course £4.99 is really £5, isn't it? But the reason every shop in the world does pricing like that is because we can't help but focus on that left digit. And there was a study that looked at, well, that may work for consumers in the supermarket, but is that relevant for clinicians? And the answer was yes, and it was based on a study of the decisions that heart surgeons make about whether to recommend to patients a particularly effective yet risky type of bypass surgery. So this isn't nurses, it's surgeons, but hopefully there are some similarities in the clinical decisions that are often made. The gist of this is, without getting into too much of the detail, is as patients get older, the risk to benefit trade-off of having bypass surgery reduces. So younger patients would benefit more than older patients, and you can see on the graph that's an age. You can see the age, as patients get older, they're less likely to be offered the surgery. And the yellow lines versus the blue lines are just either side of the patient's birthday. And the interesting point is those always overlap. The error bars basically overlap, except in one instance, which is the patients who are just about to have their 80th birthday. So essentially what this study found was, if a patient is 79 years and 50 weeks old, so just shy of their 80th birthday, they're much more likely, statistically significantly more likely, to be offered this type of surgery than a patient who's just had their birthday, who's just turned 80. Because what the surgeon does is they do that Homer Simpson thing in their head and go, oh, the patient, they're in their 70s versus they're in their 80s, even though they're basically the same age. So there's a reference there if you're interested in the paper. And in fact, all of the examples we'll mention, there's always a reference if you want the detail, because we're going to skim over the details largely and just pick out the insight. But clinicians are humans too. We're all humans too. All the people we work with are the same, similar, susceptible to these same sorts of sometimes decision-making biases. I will stop there for questions, but it's just to lead into what we're going to do next. Is we're taking this slightly backwards, but the bulk of the session that Terry will pick up after questions is we're going to get into the fun bit, which was how can we use these insights to design new ways that we might change people's behaviour to help do the things that we need to do in our jobs. And I'll explain the other steps in the process near the end. I say this is the boring bit. We want to leap straight into the fun bit. But let me just pause there for any questions before I hand over to Terry.
Hello, so we've got a couple of questions coming through. So the first question that we've got for you is behavioural science the same as nudge?
That's interesting. So you might have heard of the word. So nudge was the name of a book about 10-15 years ago, and it made some aspects of behavioural science quite popular. There was a team in the government called the Nudge Unit, you might have heard of. So essentially, nudging is one type of way to change behaviour. Often where we get to with these types of insights is you can do seemingly little or inconsequential things that can change behaviour. So you so-called just nudge behaviour by doing a little thing. And in fact, that leads to some of the examples that Terry will show next, because there's often really great things we can do without spending a lot of money. Great, very, very pragmatic. But it's really the whole approach. I'd say the main benefit of behavioural science is to better understand the problem, and that we're not doing so much of that today, but really getting under the skin of why people do what they do or why they don't do what they seemingly say they want to do. That's the real benefit, and that's in some of the resources that we can share afterwards.
Perfect, thank you. We'll make sure we share those resources with everybody. So we've got a second question come through. I think we'll only have time for 2 or 3 on this section. How is behavioural science research different from user research?
Okay, yeah. So user research is often the term used especially in digital and tech, about how we understand what users want and need and think. And I'd say the purpose is exactly the same. Behavioural science is also trying to understand those same things, but the method we sometimes layer on, more cross-cutting insights from psychology and behavioural economics and other fields. So the purpose is the same. How can we design systems around the user, whether that's patients and the public or our colleagues or clinicians? But the method can be a bit different. We can add in some different ways of working.
Thank you. I think we've got time for one more quick question on this part. So what are the ethics of using this in the NHS, and are we manipulating people?
Oh, that's okay. Good question about ethics. Well, my view is, and maybe because some of these approaches, you might say that, because I mentioned marketing, like pricing a product at £4.99 rather than £5. You might think in marketing, there's less ethics about tricking people, but of course we need to be really conscious of that in the NHS. We don't want to trick anyone to do anything they don't want to do. So it's very important all of this is done completely out in the open. But I'd say keep that question in your mind. And as Terry shows some examples, have a think through if you think any of them are like ethically dubious or how they might be, things we might want to check, particularly for, ensuring we don't increase health inequalities, for instance. Because I think it's probably in practice less of an issue than in theory. But I'll just leave that for you to think through as Terry goes through the examples next, and maybe we'll come back to that at the end.
Perfect, thank you. So just before we move on to Terry, just to remind everybody, if you do have any questions, pop them in the Q&A box. If they don't get answered live here, we will answer them offline and publish them on the website afterwards.
Okay, over to you, Terry. I'll drive the slides.
Great, thanks very much, Dan. Hi everyone, thanks for joining us today. My name is Terry McElvaney. I'm a behavioural science analyst with Dan in NHS England. And as Dan said, we're going to do this next bit a wee bit backwards, where instead of going through the first couple of parts of our process that Dan mentioned there, we're going to skip straight to the more fun part, which is the designing solutions and interventions part. So for the next part of today, I'm going to introduce you to this really good systematic and evidence-based starting point on the practical ways we can apply behavioural science to contribute to challenges such as, for example, implementing the what good looks like guidance and framework. So you can find this if you just search on Google, but I'm sure we'll also provide the links to it later on. This framework called EAST, which sets out essentially 4 simple ways to get started with applying behavioural science. And this was developed by that nudge unit in the Cabinet Office that Dan mentioned. And it sets out 4 essential ways that behavioural science can help to address certain problems. So just very, very simply, it's E for make things easy, A for make things attractive, S for making things social, and T for making things timely. So there's a lot more detail to that, of course, and that's kind of usually what our team does. We can help with that. But just these broad principles offer some really useful basic starting points for applying behavioural science in day-to-day solutions. So yeah, today, rather than going through our process in tons of detail, I'm just going to show a handful of relevant examples to bring this to life. So setting out relevant insights with examples, mostly from research published in journals, but some of it's also stuff our team's done or stuff we worked on in the past. We won't get too bogged down in details or the policy issues, but references are included, as Dan mentioned. So if you want to track through or get more detail or speak with Dan and myself, just let us know. And also, just before we dive into the specific examples and go through each part of that EAST framework, it's often useful to keep in the back of our minds a real world challenge that you or your team might be facing. So you might have one of your own, but perhaps a good general one that might resonate with many of us here. It would be like, how might we support nurses to implement the what good looks like principles in their team and organization? And we can break that down, further into smaller specific behaviors, like how might we get some of this guidance into people's annual objectives? How might I raise this at a team meeting? Or how might I secure funding or spare time to implement something new? So as I'm going through with some of these examples, do keep this in mind. So Dan, could I just get the next? Thank you. So the first of the recommendations in the EAST framework is E for easy. So we tend to know that simple is best, but we also tend to underappreciate just how important that simplicity is or can be. So we might have the best intentions. We might start with a nice simple piece of communication, for example, but because we want to make sure we're comprehensive and we've got all the important information across, suddenly our intention to make something simple and clear might not actually be followed through. So if I can just go to the next slide. So first, an example of just how simplifying a process, in this case, a prescription form, can be much more effective than maybe typical training and education. So in this study, the challenge was hospitals trying to basically read doctors' handwriting when they're writing prescriptions, which are then misunderstood by the pharmacist, potentially resulting in, serious patient harm. So basically what they wanted doctors to do was write the prescriptions more clearly. And here, your first instinct might be to give instructions or communication to doctors, like you might be at the top here on this screen. But as you might expect, healthcare professionals are very, very busy people. Just telling doctors to write more clearly might not have the desired effect. So in this project, the team, instead of providing that more training and instruction, they simply redesigned the prescription form to make it easy for doctors to do the right thing. So for instance, rather than write milligrams or micrograms, they just were given the option to circle microgram or milligram to make it easy to make the prescription form legible. And in this study, this increased simplicity, making it easy to do the right thing, reduced those sorts of legibility errors by up to 90%. So we might be able to keep in the back of our minds, are there ways to simplify how maybe the what good looks like framework or guidelines could be implemented locally? Next slide, please, Dan. Thank you. So another example that we might all be a bit familiar with, but nonetheless is really powerful insight, is the power of defaults. So what's the default do nothing option? Because we often tend to do what's easiest. We go with the default option, we just go with the flow. And if we can change that default option to an option that we want people to take, the action that we want people to take, this can make a massive difference. And there are different examples in healthcare about this, but perhaps most familiar to people is the prescribing generic rather than branded medication. So this is one study that was done in America that showed how the use of cheap generic prescriptions substantially rose as soon as they made that generic prescription the default choice in the electronic prescribing system. So you can see here on the screen in November, once that default was changed to the generic prescription, the proportion of generic prescriptions dramatically rose across the board. And the NHS is pretty good at this with regards to prescribing, but we might be able to keep in mind, what about other clinical decisions? What options are there that we could make the desired option that we want people to take the default option? And I think going back to that ethics question that we talked about earlier, we need to stress that this wasn't a mandated option. They weren't forcing doctors to prescribe the generic option here. The doctor was still free to switch to an alternative and prescribe whatever they wanted, but it was just easier not to. So again, we might be able to ask ourselves, what are those default non-tech options currently, and how could they be changed or adapted to support digital tech best practice for what good looks like? And thank you, Dan. The last example for that making things easy part is about the amount of information that we present to people. So if people are presented with too much information, they can face information overload and struggle to process the key information that we want them to focus on. Also, if we include loads of minor or even irrelevant information alongside a description of a product, that can make the product less attractive. So this is because rather than discount or ignore minor information when we're given loads of information, we actually tend to average out the information that's given to us. So if we give minor information alongside important major information that we want people to focus on, this can dilute the argument for the major information as a whole. So for example, if we list side effects of a drug, if we, for example, list risk of a headache alongside more substantial risks like risk of cardiac arrest, this can then diminish the patient's perception of the overall side effects. So in this case, less can be more. So we want to think about what are the crucial arguments for the move to digital and tech best practice, and what are the added benefits that might in fact muddy the waters. What are the key things that we need to focus on rather than throw everything at people with all the potential benefits of tech adoption. Next slide, Dan. Thank you. So that's the easy part done. But next up in the EAST framework is A, for making things attractive. So we're all very busy and distracted. We're all busy people. I'm sure we've got loads of unread emails and guidelines and reports that we want to get around to at some point. And it's hard to make the world a less busy and noisy place. So we want to ask, how can we maximize the chances that the information we're sharing in whatever format attracts the attention of our stakeholders? And this isn't just about how pretty or shiny we can make things look. Rather, it's also about how subjectively pleasing we want to make it for people to engage in the behavior that we think they should be engaging in. So Dan, thank you. So first up under that attractiveness factor is the benefit of keeping things familiar. So people tend to be more attracted to things they've greater exposure and familiarity with. The technical term for this is the mere exposure effect, but it essentially boils down to if we're familiar with something, a process, that's going to be a more attractive process to take part in. And this is one of the barriers that we often face when trying to encourage the uptake of digital tech and tech advances, as new technology can often feel new and unfamiliar, and we don't like that familiar feeling of being unfamiliar with something. So for example, in this slide here, we have the idea of recommending a lifestyle health app to patients, where previously a doctor may have prescribed them a medication. And if patients are prescribed or given or recommended a health app, they might feel a bit fobbed off. They might think, I came for a drug and I just got an app. It kind of feels like a minimum intervention. However, in this study, what they did was they added back in some of that familiarity by actually prescribing an app on a prescription pad with the doctor giving that prescription to the patient. Then this helped to make the process more familiar and more attractive and less of a minimal intervention. And this was able to overcome some of that hesitation around prescribing these app-based interventions or app-based solutions. So we might be able to think, what are the current practices that we want to retain in the new system to make that system still feel a bit familiar, to encourage people to engage with the system. Thank you, Dan. This next example is a bit from left field. It's from a piece of work that I actually did a few years ago in my previous role. where I worked with regulators in Ireland, and one of the regulators in Ireland approached us because they're concerned about PCP car agreements taking over the car marketplace. For those of you who don't know what PCPs are, you've definitely seen ads for them. They're those ads for this drive this brand new Mercedes for only £300 a month. And these are actually a fairly complicated financial product with several potential pitfalls if you're not aware of them. So we did a study looking at, one, do people understand these things? And if they don't understand, can understanding be improved? And what we did was we gave them information essentially outlining how these deals worked. And the instinct here might be to just outline in a document of instructions from the regulator's website, stating exactly how the deals work step by step. And we did do that with half of the participants getting those instructions. However, the other half of the participants were given instructions that were comprised mainly of a diagram or a graphic, very similar to the one that's on screen now, along with a bit of text. This also contained that same information. But when we presented it to them in this way, we were able to make the most important aspects of the deal more salient and attractive and easier for people to process. And when we did a round of multiple choice questions, we found that people who saw this graphic outperformed those who just got text, a block of text, by over 15% overall. So when trying to get across complex information, maybe try and keep in mind, is there a different medium or method by which is best to get this information across to people and get people to focus on the most important information that they think they really need to focus on? And lastly, under making things attractive, this isn't so much an example, but more of a principle. This is about the beneficial effects of instilling a sense of adaptation or participation through co-designing a new technology or a new way of working. And this can impact the levels of motivation to use that technology or a new way of working. And this is because people tend to place greater value on products or services if they themselves have had a role in their creation. This is sometimes called the IKEA effect, from the observation that people generally prefer a piece of furniture that they themselves have had a role in putting together, as opposed to an identical piece of furniture that someone else assembled. It also contributes to an increased sense of ownership. So we tend to value things that we own more than identical things that we don't. And the fancy word for this is called the endowment effect, but we essentially value things that we own more than things that we don't own. So we might ask ourselves, how can we encourage local adaptation of the what good looks like guidance in order to create this sense of shared ownership and participation? How can we involve people in getting this guidance together to encourage that uptake? And the next part of the EAST framework is S for social, which covers issues of how we behave in groups towards others and how we calibrate our behavior accordingly. So briefly, humans tend to act a little bit like sheep. We like to follow the flock when we can and when it's not a clearly disastrous thing to do. So if we go to the next slide, yeah. So where this comes into effect is around the idea of social norms. So we often copy the behavior of others around us, in particular people we perceive as similar to us, and then we adjust our behavior if our behavior differs from that of other people that we perceive as similar to us. And this is a really nice example of using this social norm to encourage people to behave in the way that we would like them to behave. It's actually a piece of work that Dan did a few years ago on the problem on the overprescription of antibiotics. So often people go to the GP's office with a virus that antibiotics can do absolutely nothing to help, yet they're still sometimes prescribed antibiotics. And that's a massive problem because that then contributes to antimicrobial resistance. And a solution to this that Dan identified was to use this idea of a social norm. So what they did was they selected only those GPs who were exhibiting this problem behavior, the people who prescribed that highest amount of antibiotics. And they basically told them that. They sent them a letter telling them that the great majority of practices in their area prescribe fewer antibiotics per head than theirs. And they found that this intervention, just one letter sent, on its own pretty much met the government's target that year for antibiotic prescribing reduction. I think among the research group, there were 80,000 fewer prescriptions compared to a control group. And again, at the cost of just sending a letter, so next to zero cost. So we might be able to ask ourselves, how might it be possible to share a positive social norm about the move to what good looks like best practice? Or how can we highlight when people are not part of that norm? If people in general are behaving the way we want them to behave, can we use that to encourage people who aren't behaving the way we want them to behave the way we want them to behave? And another aspect of using our social nature is by tapping into how social groups interact and how we relate to one another. One characteristic of this is something called reciprocity, which is our natural desire to return a favor. So if someone sends me a Christmas card, I generally don't really want to send Christmas cards, but if someone sends me a Christmas card, I kind of feel a need to share one back with them. So I want to reciprocate that behavior. This is another example of a project that Dan worked on a few years ago, where he applied this principle of reciprocity to help reduce missed outpatient appointments. They did this by optimizing the contents of a text reminder sent by the hospital to patients, asking them to cancel or rearrange if they can't make their appointment. So they weren't testing reminders themselves, because we know that reminders as a concept work quite well to reduce missed hospital appointments. But what they were testing was the content of the reminder. So they tested lots of variations, but they found the most effective one, which reduced missed appointments by about a quarter, tapped into this idea of reciprocity, where it shared the specific amount of money that would be wasted by the NHS if an appointment was wasted. So it might be tricky to apply, but is there a way for us to, evoke the sense of reciprocity, perhaps to other NHS clinicians, to encourage them to behave in the way that we want them to behave? And the very last part of the EAST framework is T for timely. And this isn't so much about what you communicate or support people with, but when you communicate to them. So the next part, we'll go through an example here. So first of all, the timing in which we give people feedback can be crucial. And this is another example about antibiotic prescription. It seems to be coming up a lot today. So this is a team at Derby Hospital who developed a timely feedback system to show doctors at the point they were making a prescribing decision, in this case about antibiotics. They wanted to show doctors the cost of the different options of antibiotics that they could prescribe. So a doctor might consider a tablet antibiotic or an intravenous drip. So this intervention was to show the contrasting costs at the precise moment that decision is made. So the doctors are able to get these costs. The costs are available, they're not hidden, but they're not prompted at the moment of decision to take that factor into account when they're making the decision. And this intervention worked. It significantly increased the proportion of more affordable antibiotics being prescribed to patients by doctors. So this can be something to keep in mind. How might we provide timely support to encourage and help people or nurses move towards best practice in using technology? And this is the final example. Sorry, I know I've rushed through a whole heap of examples here, so I'm sorry about that. But the final example on timing is about immediate versus long-term benefits. So generally speaking, people tend to be somewhat present biased. The fancy term for this is hyperbolic discounting, but what that just means is that we tend to prefer rewards now to bigger rewards later down the road. And this is another project that Dan was involved in, where he worked with an alcohol health charity to test different ways to motivate people to take action on their drinking. If, say, they're worried they're drinking too much or someone in their family is drinking too much. So people might visit the charity's website, and they might see a fairly typical message that aims to motivate them to take action. And as you can see on screen here, it's usually oriented towards the health harms of drinking too much, for example, an increased risk of liver disease. However, on the next slide, he compared that with a quite different message, which instead talked about how drinking too much can harm your appearance. It can give you saggy skin, it can make you fat. Of course, the NHS and this charity didn't particularly care about saggy skin, they care about liver disease. But the insight was about timeliness, it was about that present bias. It's that saggy skin is a here and now problem, whereas increased risk of liver disease is a distant risk somewhat in the future. So there's more detail in the paper, but in short, the message about the saggy skin was about 15% more likely to get people to take action on their drinking. So it's useful to ask, how can we evoke more immediate benefits of changing to digital technology? How can we invoke immediate benefits of following what good looks like guidance, even if those immediate reasons might be less important than the longer term benefits of following the what good looks like guidance? And that's more or less me. Sorry, that's a very brief summary of EAST and how it can be applied. And as we said, the links will be available there, and you can chase up any of the details of any of those articles. But I'm conscious of time, so I'm just going to pass over to Dan quickly, who's going to wrap this up in a nice wee bow.
Yeah, I will wrap this up because that's the fun bit and the practical bit that we wanted to give you today, which is this toolkit. And I hope with the examples that Terry showed, although they're from quite different healthcare challenges, the insight behind it might resonate as something practical to think on. To wrap up with that boring bit, and I'll be really quick because it is a bit dull, but is just a bit on the process, because what we've done there, to recap, is we've leapt into designing new solutions, like how to change behaviour. And that's all well and good, but unless we've first done a couple of other things, we can't really be sure those are ever the right things. So just to really quickly run through how we as a team normally work, and it's deliberately simple, so it might be an approach that you would have a go at if you did want to apply some of this EAST toolkit. Essentially, it's very first of all, be as clear as you can about the precise behaviours you want to change. So if you think back 20 minutes or so, we'd set out on the slide a fairly generic challenge that I suspect most of you can relate to. You know, how might we support nurses to implement the what good looks like principles in your team or organisation? But if you were to boil that down more, what does support mean? What does principles mean? You know, I think Terry gave some examples of, might that be about how can we change someone's, I don't know, objectives for the year, give them a specific one or more new objective, or secure a specific amount of funding from a specific person, and so on and so on. The first step really is really important, is try and boil those down as clearly as you can, because I think sometimes we're a bit general. We talk about things like how can we change the culture, and culture isn't really a thing. It's made up of lots and lots of separate things. So the first step is try and be as clear as you can about exactly who needs to do what and when, and you probably have lots of them, so you might want to then just pick on the ones that feel like the biggest points. Second point, and this is, I think it's clear, well, once you're clear what that is, then what are the barriers and drivers for that? What are the things that are getting in the way of that happening, or what are the things that are helping it that we might want to do more of? That's essentially what this phase is. And one of the resources that we'll make sure you have afterwards is, and this is a bit of a mouthful if I'm honest, but it's a really tried and tested approach from behavioural scientists that was developed from Susan Mickey's team at University College London. She was one of the SPI-B advisors during the pandemic. But it's a fairly generic and simple structure for thinking through all of those barriers and all of those drivers. And they effectively sits under three headings, which is, do people have the capability they need, knowledge and skills? Do people have the opportunity they need, which is more about external things like resources and time? And then are people motivated to take action? And in particular, if I won't go through this too much now, but in particular, going back to that Homer Simpson, Sherlock Holmes analogy, the Homer Simpson motivation is what we're focused on, that automatic motivation, because it's not that all the other factors aren't important. They really are. And in fact, they're often the most important things. It's that's the bit we often overlook. And the example that Terry run through, they tend to focus towards that. They're not only, but that's where there's our contention is there's some real benefits to be had. We're overlooking some opportunities to do things a bit differently. And that's, I think I've just got one more. Let me just see. Yeah, I'll do these very quickly. We've got some thoughts of the types of opportunities that behavioural science often can contribute to the most. You might have some, so let's just, I won't run through these, but let's save those for questions to get your thoughts. And then just to wrap up a bit about the team. So we are a team in NHS England. We sort of operate as consultants, but we're free because we're NHS England employees. So we sit in the main analytical part of NHS England. We draw on lots of different skills. So behavioural science is obviously the core, purpose of the team and the core skill set, but there's lots of other accompanying skills with that, from experimental psychology to different types of research methods. And we've got all sorts of backgrounds. And essentially we do a bunch of things. So I guess I'm just rounding off with, if you did want to get in touch with us, I'll stop showing my screen here, but do feel free either via Kate and the national team, or just ping me or Terry a message, and we're happy to, at the very least, help signpost you to, some thoughts and ideas and frameworks. But it could be there's things that we can get us stuck in and help on a bit more if we have any spare resource. But I'll just leave that up there for a moment if you did ever want to email us. But I think now we've got a bit of time left. I expect some of you have to dash off for meetings at 2, but for those who are able to stay on for another 15-20 minutes, we'll take as many questions as people have, and thoughts and challenges. Don't just limit to questions. If you think any of this was a load of rubbish, or want to delve into some detail, then let's do that as well.
Okay, so some questions are coming through, and just to mention as well, both yours and Terry's email, we will make sure that we publish this on the website after. So questions coming through then. My challenges are about cultural changes in leadership. How can behavioural science help with this?
So I'll go at that first, and Terry, you can chip in. Yeah, I think I might have just reflected on this a bit, that often, yeah, the biggest challenges that we face, certainly with digital and tech adoption, is that it needs leadership changes. It needs lots of people to do things differently. These things aren't separate. They you know, changing how we use digital and technology impacts all through different people's, you know, team roles and work roles and pay and progression issues and so on. And often we bundle those together with terms like culture change and so on. I think it comes back to the point I made just a moment ago, which is that try to boil that down as much as possible. So what does culture change mean for you? What does that actually mean? Is it about teams working together in a different way? Is it about swapping from A, analog way of working, to B, digital way of working? And then the process sort of clicks in. Then try and think through the barriers and drivers, and then have a go with this EAST framework. So I think it's all just about being as specific as possible. I don't know if Terry, if you want to add anything there.
Yeah, no, just to emphasize what you've said, where I think there's kind of an inverse proportional relationship between the benefits you can get out of trying to apply behavioral science with how specific you can make your problem area, or how well you can define those behaviors. Because like Dan says, culture changes, this massive looming thing. It can be hard to see what way to approach it, but as he says, culture is just loads and loads of little behaviors, and some parts of the culture and the behavior could be exactly the way you want them to be, and you want them to stay exactly as they are, whereas other parts of the culture, maybe there's a lack of communication between leaders. Maybe that's a more specific behavior that you can try and dive into and see what are the small behaviors that make up that lack of communication between leaders, and then you can maybe try to follow that for a more specific research question. Leaders are very important. There's a thing in psychology called messenger effects, where it's very straightforward, we're probably all aware of it, but who carries a message can often be as important as the message itself. So if you can really get leaders behind you, people who people respect and listen to, that can make your job of changing behaviors a lot easier, because they're behind the message of, this is what we want our organization or culture to look like. These are the behaviors that we want people to use in their day-to-day lives.
Perfect, thank you. So we've got a couple of questions coming in about links and resources and links to the first masterclass, so we will share everything with you at the end. But the next question with regards to this one is, do the examples you've shown work with everybody, or are some types of people, patients or clinicians, more likely to be impacted than others?
Go on, Terry, do you want to have a first go at
that? Short answer, no, we don't know. Before we apply an intervention, we might not know who it's going to work on, because as you say, it could work on certain people more than others. Different types of phenomena can work with maybe different demographics. Or I remember a previous team I worked with, the boss always said that the idea of social norms don't work in Ireland for some reason. As a people, we just don't tend to, they don't tend to work on us. I'm not sure how true that is, but these effects can definitely interact with these different demographic factors and individual factors. Just a person by person, they can vary in their effectiveness, and that's why I would tend to be a proponent of testing these changes before they're implemented at a wider scale. So like in the example that Dan had, or the example I gave of a project that Dan ran years ago, where they sent that letter to a GP's office to say, you're in the top 20% of overprescribers of antibiotics. It wasn't a case of, okay, let's send a letter to every overprescribing GP in the country, because that's you're trying to implement an intervention without actually knowing if it works. Whereas he was able to pre-test it in a smaller environment. And if you pre-test something like that, if you test it out first, then you can see how positive it's going to be if you apply it at a wider scale. Whereas, because as he said, we don't know for a fact before we implement an intervention how good the solution is going to work. So we want to do our best to identify the potential effect of this intervention before we apply it, because people are different. It's the hardest thing about, I come from a psychology background, and it's the single hardest thing is that everyone is different, and everyone might respond very slightly differently to whatever information you put in front of them. Dan, I don't know your thoughts on it.
Yeah, you covered the main points. There might be an additional inequalities point, although let's bring that back to like our colleagues. So if we were going down a route, let's say there's low uptake of a particular digital way of working, maybe a typical way of approaching that would be to provide more training, more guidelines, and those suit some people, but maybe not the people we ironically most need to reach, the people who are least likely to engage in the guidelines and the training. Whereas some of these behavioural approaches, they can, because they can be designed, and hopefully you saw this in examples, to be simple, pragmatic, not demand more time and effort and memory and attention from people. They can be a way to almost narrow some of those gaps. But I think the main point is human decision making is really complicated and context specific. So the more testing we can do, the more certain we can be what works. That was the fourth step on that process that I forgot to mention as well.
Brilliant. Thank you. So I think just one more comment that I just want to bring in, and then I'm going to hand back to our chair for close. So there was a comment earlier, while targeting the Homer Simpson clinician, there is a balance to be careful in presenting to the lowest common denominator, as you may lose engagement from the Lisa Simpsons of the world. I just wondered if you had any comments on that.
I like the Lisa Simpson mention. Yeah. Yeah, I don't think it's yeah, I think in theory, again, I'm trying to think through the examples we gave, whether any were actually dumbing down. I don't know, I might ask you, Nicole or Kate, did you think any of them, and please say it, don't feel like you're being critical, but I'd be interested if any of this you did feel it was a bit dumbing down or not quite in the custom and practice of how we need to communicate with highly trained healthcare professionals.
Thanks, Dan. I don't think for a minute it was dumbing down, and I think it sometimes bringing these examples, because it's quite intense, isn't it? Behavioural science and change, and just bringing it to life almost in a way that we can sort of resonate with. And I've gone away with the question. I'm not sure if I'm a Sherlock Holmes or a Homer Simpson, so that's one for me to take away from today.
You're definitely both. Everyone's both. I think that's,
there you
most
go.
people. Yeah.
Fabulous. Any further questions at all, Nicole, before we wrap up the session?
No, a couple of comments coming through, which I'll post for everybody to see, but in terms of questions, that's it.
Lovely. So back to me then, I think. So huge thank you to Dan and Terry for what I thought was a really fantastic session, really engaging, really informative. Thank you to all of you for joining the session. Appreciate that this is, it's a real time of challenge out there on the front line at the moment. So we really appreciate you taking time out of your day to join the session today. A couple of reflections from me. How do we embrace change? Change is part of our everyday lives, isn't it? Both within the workplace and outside of work. So today is even part of some lifelong learning. But I think it's really starting to stimulate those conversations about how do we make the What Good Looks Like framework easy, attractive, social and timely. So perhaps I hope that's really generated some thinking amongst you all, and hope you've taken away some practical tips from the session today. In the spirit of the life learning, I particularly like to keep the argument simple. So with my husband, the £4.99 will always be the price tag on items that I've purchased without his knowledge. But yeah, some really, really good food for thought for us to take back to our areas of influence. You'll notice in the chat we will be popping a link to an evaluation form. We're always really keen to get your feedback on these sessions. So please do just take a couple of moments of your time to fill in the evaluation. That really helps us to sort of curate sessions going forward, to make sure that we're delivering what you feel is appropriate to the framework. So the evaluation link will appear in the session there. And of course, nursing colleagues on the call, this is part of our continuous professional development. Personally, I've just done my revalidation, so a short reflection on today's learning will also go towards your revalidation and CPD. So that's always useful to take away as well. And of course, if you've really enjoyed today's session, the next session, which is the third in the series, focusing on safe practice, is due to run on the 23rd of February. Again, colleagues will be popping the links in the chat or in the section that you can access for you to be able to sign up to that next masterclass. And again, if you've enjoyed today's session, you may want to tell colleagues, because of course the recording will be available on the website for people to watch back at a later point in time. So I think that's everything from me. I hope you have a great rest of day. And again, thank you to our speakers and thank you to you all for joining.